Assalamualaikum everyone. Today we are going to study evaluation of lower urinary tract symptoms, which will be presented by Dr. Ajab Gul. And so we're starting now.
Assalamualaikum. We are going to start with evolution of lower urinary tract symptoms. Evolution of lower urinary tract symptoms outlines history, examination, bladder diary, uroflowmetry, and post-wide volume. Introduction. The term lower urinary tract symptoms comprise of a range of irritative, storage, and obstructive voiding difficulties. This phrase is purpose and gender non-specific and does not presume an anatomic site of origin for the symptoms. We have storage symptoms, voiding symptoms, and post-micturition symptoms. In storage symptoms, urgency, frequency, nocturia, urinary incontinence. But in voiding symptoms, patient feels hesitancy, intermittent urination, straining, and poor flow. Post-micturiation symptoms, post-void dribble, sense of incomplete bladder emptying. The lower urinary tract is composed of bladder and urethra, and the two defining functions of the lower urinary tract are urine storage and bladder emptying. Bladder filling or urine storage require accommodation of increasing volume of urine at a lower detrusor pressure. A bladder outlet that is closed at rest, absence of any involuntary bladder contractions. Bladder emptying or voiding requires contraction of the bladder smooth muscles, lowering of resistance at the level of the sphincter, absence of anatomic obstruction. There are multiple causes of lower urinary tract symptoms. Patient may suffering from urinary tract infection, foreign body, urethral stricture, distal ureteric stone, benign prostate obstruction, detrusor underactivity or overactivity, nocturnal polyuria, chronic pelvic pain syndrome, neurogenic bladder dysfunction. The symptoms mostly urinary frequency. Urinary frequency is the need to urinate many times during the day. Urinary frequency is distinguished from the polyuria, which is urine output of more than 3 liters per day. Urinary urgency, sudden urge to urinate. It is due to involuntary contraction of the bladder muscles. Nocturia, defining as the waking because of the desire to void during intended sleep or voiding that is preceded and followed by sleep. Dysuria, painful urination that is usually caused by inflammation. Intermittency, describe a urinary stream that is not continuous. Urine flow that stops and starts one or more occasions during one voiding episode. While hesitancy, trouble to start urination or maintaining urine flow. It occurs in any age, but most common in older men. Post-micturition leakage or dribble. Patient complain of involuntary leakage of urine following the completion of micturition and occurring after the man has dressed himself, usually after he has left the toilet. Urinary incontinence. Urinary incontinence is the involuntary leakage of urine. It means a person urinate when they do not want. Control over the urinary sphincter is either lost or weak. It is more common in women. There are 4 general types of urinary incontinence. Stress incontinence. It is activity-related incontinence. The most common type of urinary incontinence is stress incontinence caused by strain on the bladder, like jumping, bending, lifting, exercise, and even coughing or sneezing. Stress urinary incontinence occurs when the intra-abdominal pressure exceeds the intra-urethral pressure. Urgency incontinence is also known as urge incontinence. The complaint of any involuntary leakage of urine accompanied by or immediately preceded by urgency. It causes an urge to urinate immediately and may cause urinary incontinence if you don't make it to the restroom in time. It is a part of the overactive bladder syndrome, and 90% of men who experience urge incontinence will have detrusor overactivity. We have overflow incontinence. The overflow incontinence occurs when the body makes more urine than the bladder can hold. This may also occur if the bladder is full and can't empty, which causes it to leak. The bladder muscles may not squeeze as it should. Overflow incontinence causes frequent urination in small amounts and constant dribbling, mixed incontinence. The complaint of involuntary leakage associated with urgency and also with exertion, efforts, sneezing, or coughing. Those with mixed incontinence experience both urge incontinence and stress urinary incontinence. Nocturnal enuresis. Complaint of involuntary loss of urine that occur during sleep. Nocturnal enuresis has an estimated prevalence of nearly 10% in children aged 7 years. However, in 2 to 30% of children, it may persist into adult. Continuous urinary incontinence. Describe the complaint of continuous involuntary loss of urine. This is a rare symptom and only exists when there is a fistula. Insensible incontinence, urinary incontinence in which the patient is unaware of how it occurs. The assessment of lower urinary sensitivity using the International Prostate Symptom Score is commonly used in our prostate clinic as well. These are components of IPSS: incomplete impeding, frequency, intermittency, urgency, weak stream, straining, noturia, also the quality of life. The scoring range from 0 to 5. Divide international prostate scoring system into 3 grades: mild, moderate, and severe. Mild score from 0 to 7 in count is mild, from 8 to 19 moderate, from 20 to 35 severe. History taking in patient presenting with lower urinary tract symptoms, storage with voiding, duration, severity, incontinence episodes, a degree of bother, which symptom is most bothersome, any treatment previously impact on quality of life, any precipitating factors, fluid intake, how much volume, type of fluid intake, urinary color, timing of fluids, especially late evening, drug history, diuretics, herbal formulations, and comorbidities, previous surgery like penile, prostatic, or rectal, previous trauma, neurological disorders, past medical and surgical history. Past medical and surgical histories can affect urinary tract functions. Childhood and adult urological history should be obtained. Neurological conditions such as Parkinson's disease, multiple sclerosis, stroke, spinal cord injury, back surgery can have a considerable impact on lower urinary tract function. Medical diagnosis such as diabetes, dementia can affect continence. In women, the gynecological and obs history, including gravity, parity, and hormonal status, is important. Previous pelvic surgery can affect lower urinary tract function. Anti-incontinence surgery and hysterectomy can contribute to a variety of urinary symptoms in women. Abdominoperineal resection can result in neurological injury that can affect the function of either the bladder or the physical examination. The general appearance of a patient, including age, gait, and fragility, can provide important information regarding performance status, neurological status, and other factors that may direct proper treatment planning. Any abdominal examination, evaluation for incisions, hernias, or bladder distension. Digital rectal examination, genital examination. DRE, digital rectal examination, including sphincter tone, presence of hemorrhoids, rectal masses. In the female, the DRE can facilitate assessment of the rectovaginal septum. Laxity in the rectal sphincter tone may suggest a possible neurological defect. Pelvic examination, external genitalia, general appearance, hair distribution, lesions, urethral meatus, size, location, lesion, any prolapse, urethra, any masses, tenderness or scarring, bladder fullness, tenderness or masses, vagina, general appearance, any discharge or lesion, cervix, general appearance, lesion, any discharge, anus and perineum. Physical examination in men, genitourinary examination as it pertains to voiding function also should include evaluation of the penis for meatal stenosis, and particularly in the post-prostatectomy patient, visible urinary leakage with cuffing and straining. Examination for leakage is ideally performed when the patient in the standing position. Cuff test, ask the patient to cuff to see any leakage, check for stress, urinary incontinence. Physical examination in patient on lying position, the abdomen to feel for any masses and especially for a distended bladder and hernias. The external genitalia to examine the foreskin and external urethral meatus. The prostate through a digital rectal examination to feel the size and consistency of the prostate, as well as asking the patient to perform a pelvic skews to assess the strength of the pelvic floor.
So, any resident who can briefly describe what are the main things that we're going to look for in physical examination when a patient comes with lower urinary tract symptoms? Come on, we just told you. Yes, Hamad?
First of all, the general physical examination, and then moving forward towards the genitalia. In men, we should look for from lower to up, like
What will you see in general physical examination? What can you find in a patient with lower urinary tract symptoms?
Okay, if a patient has any heart disease or cardiologic condition, he may have he may look edematous, and the extra fluid in the body can contribute to the lower urinary tract examination.
Okay.
And also by looking at him, we can assess some of his performance status and neurologic status as well.
Yes.
If the patient can is mobile or he is not mobile.
Further?
Genitalia, we can examine meatus for any meatal stenosis, and scrotum for any and suprapubic region for any distended bladder, we can examine cloths of the patient if they have visible uh, evidence of any urine leakage.
Yes.
And there,
What about the back?
okay, the back can exhibit any spinal deformity, or it may be visible completely, or it may have a chunk of hair at the lower back, uh, which is having underlying any spinal defect, like meningocele or meningomyelocele.
And what would you like to see in the DRE of the patient?
In the DRE, first of all, rectal tone.
Yes.
If it's very lax sphincter, it may represent any spinal or neurological defect. And then in men, mostly we see the prostate, we see the size and its tenderness or any prostatic masses. Eh, Also, we can assess about any uh, vesico-rectal fistula type deformities or any rectal masses.
Okay. Moving further.
Bladder diary is a vital investigation tool as it provides objective information on the number of episodes that the patient is passing urine during the day and night. The average and maximum voided volume, hence bladder capacity, can be assessed. The amount and the type and amount of fluid being drunk, assessment for nocturnal polyuria, and whether or not there is any urgency. A 3-day bladder diary would offer. This is a chart of bladder diary. We time, type of fluid, how much, volume of urine, how urgent, leaking with urgency, or leaking with activities. Uroflowmetry. Uroflowmetry is a simple diagnostic screening procedure used to calculate the flow rate of urine over time. The test is non-invasive and may be used to assess bladder and sphincter function. In person with urinary tract obstruction, this pattern of flow is altered and decreasing more gradually. This is a basic non-invasive urodynamic test. Results of flowmetry: maximum flow rate, time to maximum flow, flow in time, voided volume, average flow rate, residual volume. In first, we see the normal curve, and second, dysfunctional voiding curve, jatular our activity. Third one, prolonged curve like benign prostatic hyperplasia. Fourth one, intermittent flow curve, neurogenic bladder, or box variety curve like a urethral structure. Post-void residual. The volume of urine left in the bladder after routine voiding is termed as post-void residual. The Agency for Healthcare Research and Quality suggests that post-void residual less than 50 ml represents adequate emptying, and post-void residual greater than 200 represent inadequate.